Hello, everyone. Welcome to today's session. For those of you who don't know me, I am Amy Stanford. I am one of the co-chairs of the TNE Foundation's curriculum. So welcome to our first session of this academic year. Welcome to our new fellows who have probably all just started in the last week or so. So thank you all for attending. So today we are going to have a wonderful lecture, but first a few kind of housekeeping things. I do want to remind everyone that and acknowledge Mallinckrodt Pharmaceuticals because this series is supported by an educational grant from them. And then as a reminder to those of our audience members from Canada that this lecture series is now a self-approved group learning activity as defined by the Maintenance of Certification Program from the Royal College of Physicians and Surgeons of Canada. And as a reminder for those who are newer today, we're going to first be having our talk by Dr. Dany Weisz on the evolution of hemodynamics. And then after he is done with the talk, we'll have some opportunity for Q&A. And so please, this is a great time to ask your questions. And we have a really great resource in Dr. Weisz here today. And he doesn't need much of an introduction, but he is a neonatal intensivist and director of the Neonatal Hemodynamics and TNE program at Sunnybrook Health Science Centers in Toronto, Canada. He's an associate professor in the Department of Pediatrics and the faculty in the Institute of Health Policy, Management and Evaluation and the Institute of Medical Science at University of Toronto. He has received funding from the Canadian Institutes for Health Research and other sources for national clinical trials in the field of neonatal hemodynamics. We're so happy to welcome him back. He was actually the inaugural co-chair of this lecture series, so we're excited to have him back today. And as a reminder, everyone, please feel free to put questions in the Q&A or the chat, whichever is available to you. So I'll let you take it away.
Thanks so much, Amy. Real pleasure to be back here after sitting in your chapter, having sat in your chair, Amy, for a couple of years. And a warm welcome to all of the new hemodynamics trainees and some of the older ones who I saw popping up. Thank you for joining, and thank you for the opportunity to talk about the evolution of NHTNE, looking at how the indications and especially the education and integration has evolved over time. I know Patrick did a talk on the evolution of specifically TNE, so I'm actually going to avoid talking about the bits and bytes of echocardiography evolution. And this is going to be slightly different, not the heavy evidence-based medicine talk, but a conglomeration of a number of things. It'll be part history lesson, part lived experience, some aspects of physiology, a review of relevant current events in neonatal hemodynamics, as well as some evidence-based medicine. I think everyone who's joining us today already knows what NHTNE is about, and that is the clinical and echo assessment by the neonatal intensivist for the neonatal intensivist. And the major evolution over the last kind of 5, 10, 15, 20 years has been a sharpening, a delineation and distinction of what exactly NHTNE and the field of hemodynamics and neonatology really means. Within cardiac ultrasound in the NICU, there's two main types. There's cardiac focus and there's consultative echocardiography, which is performed by the imaging team. In contrast, cardiac focus is really about the primary neonatologist performing some degree of a limited echocardiography to glean critical information. For basic cardiac focus, it is 1 or 2, maybe 5 pictures. Is there a pericardial effusion and associated tamponade? How bad is the LV dysfunction in this baby with cold septic shock? There is an advanced cardiac focus which straddles the bridge between the basic, the 1 or 2 pictures, and the more complete TNE scan. And that still is yet to be defined, but likely includes some degree of critical care echocardiography. And I think as educators in the field, as long as someone is competent, no one really cares whether you do a 5-picture scan or you do the full scan, but that competency cert is a must and has generated, or concerns about competency has generated controversy about what an advanced cardiac focus actually means, but more on that in a little bit. For imaging and consultative echocardiography, we have our pediatric cardiology colleagues who are, of course, invaluable and often take a more anatomical slant in echocardiography. And there's us, the neonatal hemodynamics subspecialists who perform comprehensive TNE. So NHTNE is a hemodynamic consultation. That consultation model is the dominant paradigm, the dominant workflow in almost all institutions around the world. It is comprehensive yet rapid imaging, and by the end of your training, you will be doing 80 to 100 pictures in 30 minutes. And is most importantly integration of clinical and echo information with recommendations for intensive care management. What it isn't is it's not cardiac focus. Our cardiac focus is limited in scope, often due to lack of training, and NHTNE is not. We can do neonatal hemodynamic specialists can and do many full scans, and we'll liaise with the cardiologist if we think there's an anatomical problem. It's also not a rapid anatomical evaluation. While we may scan rapidly, it's not cursory. Often we perform a full anatomical scan and have that reviewed by the cardiologist. So we're not the definitive anatomist drawing conclusions, but certainly we often take all the images and for the most part make those diagnoses before them. So how has the hemodynamic consultation evolved in the NICU over the past 20 years? I'm going to take you back to 2005, just as I was still finishing medical school. But back then, it was the cardiologist. Cardiologists provided the echo and consultation to neonatologists in the NICU for all structural and hemodynamic concerns, and that was it. But now, certainly in place in most centers between 2015 to 2025, is this consultative model where the TNE neonatologist provides that critical care hemodynamic consultation and then works in tandem. There's a collaborative tiered model with the cardiologist. The cardiologist still plays a critical role, but the intensive care part, the intensive hemodynamic decision making, that is now done by the hemodynamic neonatologist. So if you were to wonder, what did life look like back in 2005, even 2010? Well, if you had a baby where you were worried about PPHN, you would call the pediatric cardiologist at 3 in the morning. They may or may not appreciate the call to various degrees. And while you're waiting for them to come, you would initiate empiric therapy. But you had to ask yourself, well, what is the underlying pathophysiology, if you even thought to think about it? And you had to use your available faculties, the clinical picture, the history, physical exam, radiology tests, laboratory, to make an educated guess. And based on that guess, you would start some initial therapy, and hopefully you would have the assistance of the cardiologist by that time who would tell you whether this is or isn't in part congenital heart disease and provide you with some indices, often limited, for what is the cardiac function and the shunts. Then you had to decide, what do you do with that information? And you may or may, the neonatologist at the time may or may not have known what to do with that information, but they were kind of forced to titrate or modify intensive care. And now the well-entrenched neonatal hemodynamic consultation service looks like this. So you can still call your friendly neonatal hemodynamic specialist for your baby with PPHN, and what you get is a comprehensive functional and often anatomical echocardiogram. If there is suspicion for congenital heart disease, then we get in touch with the pediatric cardiologist for immediate consultation. And if not, well, the pediatric cardiologist can review when they're available. And most importantly, what our general neonatologist colleagues get in return is a comprehensive description of the current physiology and recommendations for intensive care management to help titrate and modify intensive care. And my favorite part is the frequent and longitudinal reassessment. This is the bread and butter. This is the foie gras for neonatal hemodynamics consultations. It's not a one and done. We don't leave. We stick around until the baby's better. And that is where hemodynamics consultation, I think, is a win. So over the last 5 to 20 years, NHTNE has really come into sharper definition. It's come into a sharper definition, sharper focus, and distinction of exactly what it is. And current hemodynamics programs are multi-tier. They have clinical care, formalized education, research branches, and focus on innovation. And in addition, there's clear delineation now, or more clear, of what does it actually mean? The turf wars of 5 to 15 years ago. They're done. Pediatric cardiology colleagues are anatomically focused, but they're limited in their ability to provide mechanistic insights into exactly how to manage these babies in an intensive care setting. Cardiac focus has a very important role, and there's a move afoot to train all neonatologists in cardiac focus. That is already there. It's going to happen, and we have to do it as us as the predominant educators have to do it in a thoughtful, productive, and structured way. Nonetheless, neonatologists with cardiac focus training and experience, they still risk a flawed understanding of the overall hemodynamic state. And their main issue is not they shouldn't overstep their boundaries. On the other hand, neonatal hemodynamics is in that sweet spot. We really are hemodynamics experts. We do a comprehensive scan, really get a sense of what is the underlying physiology and where to take it. But the limitation is in the rigorous training requirements. It takes time to become an expert in neonatal hemodynamics, but that's why all of you guys are here. And we hope that you enjoy your training. The proof is starting to be shown to be in the pudding here. And I'm going to show you very briefly some data that TNE changes management and saves lives. So this is data from Toronto. There's data from elsewhere for sure that TNE findings compel clinicians to alter management. And amongst babies with PDA, pulmonary hypertension, and shock, for babies with pulmonary hypertension, TNE findings change management in 58% of cases and change management in 81% of cases of shock. I don't think, certainly not news to anyone here, but important to know that it does compel clinicians to change the management. And most importantly, I think this is probably a prominent piece of work that did come out of the Toronto group, but that hemodynamic consultations seems to save lives. This was a very large cohort study of, I think, 600 critically ill neonates. And we found that for neonates that had a hemodynamics consultation in the first 24 hours after birth, that exposure to hemodynamics consultation was associated with nearly a 30% reduction in mortality and the composite outcome of mortality or severe cerebral hemorrhage. And that is after adjustment for all of the possible covariates known to man. And even though the critically ill babies who were exposed did in fact have much higher illness severity than the unexposed. The natural question to ask, which has been asked of me, and I'll explain in the next slide, is that, well, if TNE is so great and it changes management, shouldn't all neonatologists be TNE experts? And is this where the field is going to evolve to in the future? What is the best model for TNE-guided neonatal critical care? And on the right is a drawing from Satyan Lakshmi-Nrsimha, where the complaint about the current dominant neonatology hemodynamics consultative model is that the primary care neonatologist is still a bystander, still sitting on the sidelines, giving up some degree of the care to the neonatal hemodynamic specialist so we can parachute in and do what we do. But there are issues with that, which I'll address. The good part of the consultative model is a structured approach and consistency, generally extremely highly trained individuals with great expertise who can perform advanced imaging and provide interpretation. And a consultative model is faster to adopt in academic centers rather than waiting for everyone to be trained before launching. But there is a move afoot to question whether the primary neonatologist model is the way to go. Not for everyone, but for neonatal intensivists. We all know that neonatology is a hybrid. There are some aspects of neonatal intensive care that are less intensive, and there are some aspects that are certainly fall into the realm of critical care. But should those neonatologists who practice truly in neonatal critical care have that TNE training? And my personal anecdote is that at least half of my critical care training happened during my TNE fellowship. The upside of this type of model, which is not in place anywhere in the world, is that if the primary neonatologist is always a TNE expert, you will never have an issue of timely intervention in acute deterioration because you're there. On the other hand, the issue is the need to train a large number of neonatal providers, and the duration of that training is prohibitive. It would certainly have to be included as a mandatory third year in training. In Canada, core neo-peri training is only 2 years. In the States, I believe it was still 3 years. Please correct me. But we might need an extra year because that third year was often focused on research. The anecdote I wanted to share with you is that as we were putting NHTNE to the Royal College for consideration for accreditation and for recognition as a subspecialty of neonatology, the main stumbling block actually was that the specialty committee asked me to give a deposition on, if it's so important and it saves lives, why isn't it that it's mandatory training for all neonatologists? Why is it only going to be a consultation model? And so it required a trip to Ottawa for me to explain in front of the committee the resources required, the exceptional level of the extensive extra training, the lack of training facilities, and the general infeasibility of simply training everyone. As I heard in the warm-up to the talk today, that there are 63 neonatal hemodynamics trainees in training around the world. And my guess is that in 10 to 20 years, we may be moving closer to the blend that neonatal critical care will involve TNE training. So just to summarize, over the past decade, the scope of TNE has certainly come into sharper focus as distinct and simultaneously complementary to other forms of cardiac ultrasound, both cardiac focused and more anatomically focused ultrasound. And that TNE neonatologists increasingly are performing that full anatomical and functional scan, and doing this not because we necessarily want to, but it's important to know. Your PPHN baby at 3 a.m, you need to know, is this obstructed or an anomalous veins that needs surgical consultation, or is this normal anatomy we can manage with our hemodynamic abilities? So it optimizes efficiency, it reduces repeat echocardiography, and our cardiologists generally love it. So what about indications for TNE? These, I don't think we need to introduce these to great detail. They have relatively stayed the same over the last 5 to 20 years. They include PDA in preterm babies, low systemic blood flow states during transition, acute pulmonary hypertension, shock, HIE, and chronic pulmonary hypertension. And then included the specific goals of the TNE consultation to the right of that table. Now, what has changed is the development of frameworks for help trainees understand the approach to NHTNE cases, providing a step-by-step, almost recipe-like, if you'd like to call it that way, so that trainees can really have a sense of how to move forward. And that is a very simplified, perhaps oversimplified, 3-step framework. For anyone who's already in practice, this may seem oversimplified, but really is geared toward helping trainees understand how to move from information to decision-making to selection of therapeutics. So step 1, especially as a new trainee, is when you're faced with a sick baby, to identify what is the current cardiovascular physiology, what's the derangement going on. And to do that, you have to integrate the clinical assessment, including lab data, radiographic data, as well as the echo data to define the neonate's current hemodynamic status. Once you've done that, with your understanding of the natural history of the disease, the underlying pathophysiology, what is normal and abnormal, and what those limits are, you have to determine what is the desired physiology. If you could snap your fingers and make the physiology different, what would you choose it to be? And therein lies this is the hardest part, defining individualized hemodynamic goals based on your knowledge of the pathophysiology, natural history, and the baby's current status. And finally, once you've done number 2, step 3, which sometimes is difficult, but once you've done 1 and 2, becomes more straightforward, is determining what are the optimal intensive care therapeutics. So personalizing and titrating therapies to move from step 1 to step 2 and achieve that desired physiology and improve outcomes. It can look as simple as this type of table. This is an elemental or iterative physiological approach to hemodynamic decision-making. And what it involves is listing the key hemodynamic parameters. For me, I listed the top 8 there in the first 8 rows. And certainly not, perhaps slightly less important, still important to be included, but kind of the rest are jammed at the bottom. But the most important parameters for me are SVR, PVR, LV, and RV systolic function, the ventricular outputs, and the shunt size and direction and level of restrictiveness. Chamber sizes, wall thickness, diastolic function, intravascular volume, pericardial effusion, other shunts, those are certainly important. I leave them at the bottom so that I include them in notation and in case they play a role, but the top 8 are generally the most important for me. I think there's no better way than to work through a framework using a case example. And this is an example that we recently had here at Sunnybrook, and it's that of a 33-week gestational age preterm baby. The pregnancy history was notable for the presence of a left lung CCAM that involuted by the late second trimester. The baby did have unexplained polyhydramnios in the 2 weeks prior to delivery, and there was otherwise normal fetal anatomy. The baby was delivered at 33 weeks because fetal tracing identified a non-reassuring fetal heart rate, and so the mom was taken for an emergency C-section. Incidentally, we were told that there was biventricular systolic dysfunction on the pre-delivery obstetrical ultrasound. Because of the urgency of the C-section, there was no beta-methazone administered, and APGARs were 8 and 9. The baby came out in good shape and was stabilized on CPAP. Clinically, the baby appeared actually quite well. The baby was on CPAP 6 in room air. The blood pressure was normal. Clinically, the perfusion was normal with normal pulses. From a laboratory and organ perspective, the blood gas was normal. The lactate was normal. And we did do an early hemodynamic assessment at 4 hours of age just because of the history of obstetrically identified biventricular systolic dysfunction. And we did indeed see on our echo moderate RV systolic dysfunction, normal LV function, normal RVO, LVO, and a PDA that was moderate in size, left to right, but restrictive and non-pulsatile. So we were generally happy with the clinical status of the baby. We thought if the RV systolic dysfunction was related to placental issues, the baby being born now would likely improve that. So we opted just to watch and wait. But what happened is that some unexpected developments occurred. That after the first 24 hours, the baby developed severe systemic hypertension. I'm not sure if you can see my cursor, but the first 24 hours, the mean blood pressures were certainly robust, but not high. But after that, the mean blood pressures were well above the 95th percentile and mostly above the 99th percentile for gestation. It was a combination of both the systolic and diastolic. We did do a repeat hemodynamic assessment at 48 hours because of the systemic hypertension, both to see if there had been any progression or improvement in the RV function and to identify whether there was any associated LV systolic dysfunction from this severe hypertension. Clinically, the baby was fairly well. As you can see, the blood pressure was 125/71, so the baby was profoundly systemically hypertensive. The urine output was normal. Baby did appear clinically mottled and vasoconstricted, and with a delayed cap refill time. From a laboratory perspective, there was an evolving mild metabolic acidosis with a rising lactate. Truthfully, we were surprised that on the echo, as you can see the peristernal long axis view here, the RV systolic function was normal, but there was new moderately decreased LV systolic function with an ejection fraction of 43%, as well as probably overall moderately reduced biventricular outputs. The PDA was now closed, and we did pay careful attention to the arch, which was normal and unobstructed. So putting this framework into practice, our current assessment of the baby's current physiology was a high SVR state related to the severe systemic hypertension associated with decrease in LV systolic function, and having had the first echo with normal LV function and now LV systolic dysfunction in the setting of systemic hypertension, seemed likely an LV afterload issue. There was, as you can see, the biventricular decrease in output, and there was also some degree of LV and LA dilatation. So this is a fairly classic example of increase in LV afterload related to the LV systolic hypertension. It's an example of ventricular arterial uncoupling. And so what you see here are pressure volume loops, idealized pressure volume loops of the left ventricle. The pressure volume loop in blue is for a baby with a normal blood pressure, and the one in red is the one in a baby with a higher blood pressure. When the blood pressure was normal, the baby had a normal arterial elastance. And as the blood pressure has significantly increased, the arterial elastance increases. And the result is that the ratio of arterial elastance to ventricular elastance changes and becomes unfavorable. So the desired changes in terms of helping this baby hemodynamically was to effect a decrease in systemic vascular resistance through an antihypertensive, but also to improve LV systolic function and increase biventricular output. So I do have a couple of poll questions in this talk. And the first one is, given the current status, the desired status of the baby in terms of hemodynamic changes, which therapeutic agent would you recommend? Great, thank you. So there's a fair, I'd say a fairly even distribution, though milrinone does squeak out ahead. And the answer matters less than the thought process here. So for trainees, if you are filling in your framework to figure out what to do here, what you can do is identify therapeutic agents that modulate each individual hemodynamic parameter. So if you're looking for an antihypotensive to decrease your systemic vascular resistance, nicardipine, milrinone, and nitroprusside, they will all do that. For increasing LV systolic function and increasing biventricular output, however, it's basically low-dose epinephrine, milrinone, and dobutamine. And then the intention of the framework here is for you to look across all the therapeutic agents that you listed across each domain, identify the one that is common across all of them, and that's generally going to be the best one. So milrinone in this particular situation, we thought was the best one because of the LV systolic dysfunction. I think if you had mild dysfunction and you chose simply a systemic vasodilator that like nicardipine, that might have been okay. For us here, because the LV dysfunction seemed to have progressed quite quickly, we did want that inotropic support. And in case you're wondering what data there might be for milrinone in these situations, well, milrinone is tailor-made for situations of increased LV afterload and low cardiac output. On the left is data from a clinical trial, it's now quite old, from 2003, for the efficacy of milrinone in preventing low cardiac output syndrome in infants and children after pediatric congenital heart disease surgery. And they found in an ordinal fashion that increasing doses of milrinone decreased the risk of low cardiac output syndrome in infants and mostly infants. For neonatal specific data, data from my good friend and colleague Amy Strain and Patrick from when he was in Toronto identified in a cohort study that targeted milrinone prophylaxis for babies after PDA ligation. This was much older data, was associated with a significant decrease in post-PDA closure syndrome and need for inotrope. So if you're ever in that situation of hypertension with low cardiac output state and LV dysfunction, milrinone is the top agent to use. So the evolution for NHTNE has not been so much an indication. Certainly there are different ways we're evaluating babies, we're taking more in-depth pictures, but the development of these types of iterative frameworks to help especially our trainees identify how to take on NHTNE cases, and first identifying the current physiology, then the desired physiology, and then figuring out what agents to use to move from step 1 to step 2. Since simultaneously, as we've seen sharpening of the scope and focus of NHTNE and development of frameworks to help trainees learn the integration of echo data into clinical care, we have seen major leaps in the structure of NHTNE education. And I don't think any of us here were neonatologists 25 years ago, but at that time, neonatologists who were practicing in TNE were generally self-taught. And Patrick was one of them, Martin Kluckow and Nick Evans in Australia. They were generally self-taught. There was no real formal oversight. They may have had some experience learning with pediatric cardiology. But that evolved to about 5 to 10 years ago, where training programs were now much more structured. They typically they had to occur in institutions that had TNE consultation services. They often involved training in structural heart disease using pediatric echocardiography labs. There were typically a smaller number of faculty at each institution, usually one or two or three. Training was still largely experiential. It was learn to scan, then you go scan all the babies every day and review with the staff, on a daily basis. There was fairly limited formal teaching. There was really no formal evaluations that were competency focused and iterative performance evaluations to guide performance mapping. And that, I think, over the last 5 years has been really a huge shift, that the modern structured training program in NHTNE now much more closely resembles the classic neonatal perinatal medicine training program than it does the experiential versions of years gone by. So most training programs now have theoretical instruction, robust one-on-one imaging training, formative feedback, including oversight from training and competency committees, specific competency assessments, either direct observation or knowledge assessments, objective structured exams, and a compilation of entrustable professional activities, as well as portfolio reviews. There's a focus on iterative performance, as well as targeted remediation and continual skill refinement. And most programs now mandate some degree of research methods training and scholarly activity. I'm proud to have been involved in the Royal College recognizing NHTNE as an area of focused competence, basically as a subspecialty of neonatology. It did take a tremendous amount of work and convincing at the Royal College, but this recognition, I think, was a big one and the first internationally. The relevance, I think, for current trainees is that if you're looking for a comprehensive set of training requirements, knowledge elements, and a competency portfolio, and if you're a program director looking to make the program in line with standards of accreditation, I think you need look no further than the Royal College documents, which are freely available, and I do encourage all trainees to take a look. Currently in Canada, there are 3 accredited training programs and 4 unaccredited, although all 4 unaccredited programs are actively undergoing the accreditation process. A couple of years after the Canadian guidelines were published, the US guidelines were published by the American Society of Echocardiography. It was lovely to see the underlined green, all the neonatologists involved in these guideline publications, whereas the first iteration published back in 2011 was really driven by pediatric cardiologists. As a trainee, even more so than the Canadian documents published by the Royal College, I really think that if you're new to the field, the ACE guidelines should be your first go-to Cole's Notes Bible for neonatal hemodynamics. So it's where I would send all my trainees to read and ideally memorize every word in there, because it really is a really wonderful and thoughtful summary. Included in the American guidelines are guidelines for training and accreditation. And I wanted to point out that the Canadian and American guidelines for terms of training and accreditation are essentially the same. And this was done by design. We knew the American guidelines were coming out, and I had the fortune of spearheading that part of the American guidelines. And there was broad agreement that because the Canadian guidelines are actually extremely comprehensive, it would be worthwhile to have that same set of comprehensive guidelines for training in the American guidelines, and to have the goal for broader, certainly North American standardization of NHTNE training. In terms of an international comparison, there is continual improvement in many other jurisdictions as well. So Australasia has also recently revised their training guidelines in 2024. Their duration of training is listed as recommended 18 to 24 months, although not prescribed. They do require an interesting hybrid of at least 75 echoes, and trainees have to send in to the Australasian Society of Ultrasound and Medicine a set of really DICOM studies for objective review. And there is also a set of objectives and competencies that they have to meet. In Europe, I was been permitted to share with you from my colleague Willem de Bood, who's in Netherlands, that they are very soon to launch the neonatologist performed echocardiography training paradigm across multiple centers in Europe. with a duration of training of anywhere from 6 to 24 months, competency-based again, though without mandatory pediatric echo labs, often I understand because they're not routinely available in Europe. At the moment, the only nationally accredited programs are located in Canada, though there are moves afoot to spread accreditation to other centers. This is a map of Europe showing where the locations are in the UK and Europe, and there is a training program in Qatar, which has ties to the to neonatologists perform echo in Europe. Okay, I've taken you through evolution of NHTNE in some degree in practice, in definition, in scope, in indication, and in training program. What does the future hold for education at NHTNE? And there is much to be said about AI. I think it's touted as the next big thing in terms of training, especially as in sonographer training. It is close. So this is an example of a deep learning algorithm that provides effective real-time assistance for image optimization. What you see in this video is there's a trainee who's scanning, and the algorithm is giving instructions like rotate counterclockwise slowly, hold for recording, so that the best images can be obtained. And so this obviates the need for a one-on-one sonographer to be there and hand-holding with trainees, especially early on in their training. Now, does it work? The answer is yes. So this is only done in adults so far, but in this cohort study of novice nurses who had never scanned before, but who had an hour or two of basic training, and then they were told to go scan using with help from this deep learning algorithm. The nurses that scanned had images of sufficient quality, as you can see in the table. The first table, almost 99% of their images were of sufficient quality, which is quite remarkable for just learning echo for the first time 2 hours before. And then in comparison for these novice nurse sonographers to expert sonographers, their quality of their examinations were minimally inferior. They were small 1 to 4 percentage points lower in terms of image quality compared with expert sonographers. So it really highlights, I think, the potential in NHTNE education to relieve some of the burden that we place on sonographers. The sonographer expert could be a physician, it could be a nurse practitioner, it could be a dedicated sonographer. Their time is valuable, and if part of this can be done with AI, that would be certainly a resource-saving measure. So NHTNE is education and evolution, and I feel like we're living through that now. We discussed how 25 years ago to 10 years ago was a big shift from unstructured to more experiential training programs, and now is kind of the modern structured training program has really taken shape across most of the world. The future still to be decided, of course, but there's a reasonable likelihood that deep learning algorithms are going to assist us, at least in some aspects. And if you believe in the simplified framework that I presented to you earlier, there is very, very likely a very easy way to create that into a deep learning algorithm that we can open up on our phones just like we do open evidence, and it can guide us in the same fashion. Okay, the last part of the talk in the closing few minutes is a look at some of the pitfalls, just some friendly advice from me to our new NHTNE trainees on how to succeed in this upcoming year. And the first question I'd like to ask of you is, which of the following domains of training, and I've listed the 5 major tasks of being a TNE neonatologist, which of these domains of training do trainees in hemodynamics struggle with the most? But it looks like there's a fairly even spread, but the answer, and this comes from my life experience and discussions with other educators, that the answer is integration. And so one of the pitfalls I want to bring to your attention was over focusing on um, the technical slash image acquisition skills in the first months of training. There is a panic amongst trainees, especially early on, because the process of learning the technical skills of imaging is overwhelming, daunting, and it is a necessary step, of course, to achieve competency as a TNA neonatologist. However, I would say some trainees forget that lurking behind the wall of image acquisition, which is hard to see over, especially in the first few months, is that wall of integration. And the process of understanding how to integrate clinical and echo data into treatment recommendations, including revision of those recommendations, is a skill that takes much longer to develop in trainees. And that's the one that trainees struggle with the most, especially as they're nearing the end of their year of training. What I've shown on the right is a schematic of the time course for skill acquisition for each of these major tasks. And what it shows is that measurement and analysis is really a focus and a hyper focus over the first 2 months. By the first one, maximum 2 months, you must be able to do all the measurements and all the offline analysis to a high degree. Image acquisition the focus is really over the first 6 months, though continues, and you should be fairly competent at image acquisition by 10 months, and I would say most trainees are. And integration of the clinical and echo data takes the longest. And while we really lean on it in toward not so much in the first quarter, but certainly the last 3 quarters of training, that is something that I strongly urge all trainees to do. But how do you do that is the question. What does it mean, and what do you need to do to learn how to integrate clinical and echo data into clinical treatment recommendations? The basis of it is sound knowledge in hemodynamics. So first is to understand the patient. What are the disease states, their pathophysiology, as well as the image analysis and measurement, which you are absolutely going to learn in the first 1 to 2 months. The second is to know what should be the physiological goals of care. What's the natural history of disease? And what are the normal limits of neonatal cardiovascular physiology? And finally, you need to know the tools of the trade. You need to know cardiovascular pharmacology in and out. And it's not that difficult, in my opinion. There's probably 10 drugs that you use most commonly, and it's not that hard to learn the pharmacokinetics and pharmacodynamics of 10 medications. Of course, there are some on the periphery that you will use less often, but if you even focus on the 10 most commonly used agents and have a sound understanding of cardiopulmonary interactions, and you're already ventilation experts, you can put this all together into integration. So my take-home message is don't forget to do this in the first few months while you're stressed out and focused on learning imaging. Okay, pitfall number 2 is not using your time in NHTNE to develop expertise in POCUS. I don't mean cardiac POCUS. Anyone who does NHTNE can do POCUS at will, but you can do once you can image the heart, you can image anything. Of course, it does take some training. So I hope that you do have some people, if not the hemodynamics people, but someone doing POCUS in your institution. You're going to be echoing so many babies, hundreds and hundreds of babies. It is not too much extra to also, as long as you're allowed to, of course, to also look at things like ET2 position. So on the left of your screen is I've overlaid some graphics just to show what's what, but you can see the endotracheal tube. And this endotracheal tube is deep. We know it's deep because it's extended past the aortic arch. And it's not that they're touching, of course, in real life, but just that the aortic arch is at the level of the carina. And so if the ET tube is below the level of the arch, then it's likely a main stem bronchus intubation. To the right was a recent scan that we did to exclude pneumothorax in a neonate with sudden onset hypoxemia. And the ability to use ultrasound, lung ultrasound, to exclude pneumothorax is, I think, a pretty important skill, especially for a baby that's rapidly deteriorating. As I mentioned, neonatal POCUS has many different facets, which are very useful in neonates. And that cardiac sonography is the hardest. Evaluating this intricate, complex, three-dimensional, rapidly moving organ in real time using 2D ultrasound slices and putting it all together is the most challenging. All other structures are either physiologically or anatomically simpler or both. And so TNE fellowship is often an opportunity to learn it all. And my third piece of advice is that if you in the future you are thinking of starting or expanding a NHTNE program, I think it's important to start that process soon. And because building with multidisciplinary collaboration is a must. TNE program requires collaborations with pediatric cardiology, radiology information systems, sonographers, often allied health professionals, um, as well as in-depth processes like a TNE atlas, imaging protocols, um, imaging software, archiving software, as well as training mechanisms and escalation for when any of these processes go wrong. So engaging the leaders at your institution, getting their buy-in, ensuring there's capital funding because this is a very capital heavy costs, certainly for startup. So including those things in future budgets is going to be a must. Otherwise, you might be finishing your training, going to your home institution, and be in the unfortunate position of really not being able to launch. So the take-home points overall is that I've taken you through how NHTNE has really gained more clear distinction between the scope and workflow of the human dynamics consultation, between that pediatric cardiology and cardiac focus have really become more clearly defined over the past decade. I've shown you how, while the indications for TNE have remained relatively the same, that there's an advent of simplified frameworks to help trainees move in an iterative, almost recipe type but structured approach to learn how to integrate this information into clinical care. I've taken you through the evolution of NHTNE training programs, how education is starkly different now than it was before, and I think potentially bright future of integration of things like AI. And finally, I ended with just some sage pieces of advice. You can take it or leave it, but to try and learn POCUS during your fellowship training in NHTNE because you're going to be scanning these babies anyway. No, don't forget to consider the integration piece. Don't just worry about image acquisition, but put some effort into getting that background knowledge to be able to put it all together. And finally, if building an NHTNE program is in your future, consider making headway to establishing support from institutional leadership, including major items like capital startup costs, IT and IT connectivity. It's important for you to identify champions, plan, and network. And thanks so much again to Amy and the entire NHRC for the opportunity to chat today. I'm looking forward to a lively discussion.
Thank you so much, Dany, for that really wonderful, wonderful talk. I will invite all of our attendees to go ahead and put questions into the Q&A or to the chat box, whatever is available to them. And I think we'll spend a few minutes with the entire group before we have a closed session with our trainees. One of the questions from the audience, Dany, was you talked a lot, or you didn't talk, sorry, you talked a little bit at the end with POCUS and how utilizing your TNE year to also learn POCUS. Do you think, though, that with the way that the field is going, is it something that every pediatric resident or even just every NICU fellow should learn POCUS?
Um, I think the horse has left the barn. POCUS is here to stay. Uh, the question is, what is the domain for use, and what are the capabilities and uses that will be employed for, and then how to establish competency. For example, POCUS for vascular access. I'm not sure that's actually POCUS, but using ultrasound for vascular access is a ubiquitous skill. I think there are many areas of, especially in North America, where vascular access is not necessarily a strong technical strength for trainees, and ultrasound can really augment that. And there's nothing more harrowing in clinical practice. If you're in the community and there's a baby coming in, if you're a community center and there's a sick baby and none of the adult nurses in Emerge are getting an IV, well, you're the one that's going to have to do it. So IV access is a no-brainer because it doesn't require image archiving. If you're thinking of using it for intensive care assessment, that's where I think you need to have adequate training, and you need to be confident in your skills um, before you use it. But I think it's here to stay. It would depend on the domain that you intend to use it on and ensuring that you get adequate practice.
One of the things I thought was striking is when you put the four different areas, Canada, the US, Australia, and then Europe, as they're trying to determine, how do you determine you're competent in TNE? And one of the things that we talk about a lot is, and you kind of mentioned, yes, you need to do echoes in order to, acquire the images, but one of the biggest things is integrating that knowledge. But what is your take? It was very interesting to me to see, those that had numbers of echoes on there. The US was more than 250, Australia was 75. Thoughts on that very strikingly different number, and do we even need a number?
Um, so the number is a poor man's substitute for competency-based evaluation. That's what it was. Um, and because we now have, or I think all centers, as you can see, these training sites and continents involve, in fact, all of the training centers around the world. They're all competency based. I mean, if you can achieve it through 75 echoes, well, I think you're just a superstar, or you probably learned echo in a previous life and somehow remembered it. In general, it takes at least 250 echoes for competency in image acquisition, and I think you need plus echoes for the integration piece. It does take much longer. You need volume of cases. Those cases, they're not those babies on multiple cardiovascular medications. They're not there daily. Maybe in Iowa, perhaps, but maybe it's weekly in other centers. And so you need the time and you need to be doing those cases and that volume to have experience to anchor that knowledge into clinical practice. I can tell you that ideally, smilrenone, the pharmacokinetics are a bolus dose of 50 mics per kilo followed by an infusion of 0.16 based on published data. But you need to live that, and if your baby already has a diastolic blood pressure that's low, you're going to rethink that, or you may do it much more judiciously. Um, and you need those experiences to anchor that. You need that footing, the cement foundation, and that's you're not going to get that in 75 echoes. I think the key is competency based, and really it's been appealing to see how everyone has moved toward that over the last 2 to 3 years.
And then I think we'll just do one final question before we switch to our small group. One from the audience. For physicians who completed their training, several years ago, they've been out being a faculty. Are there alternative pathways to acquiring this knowledge other than a formal fellowship? It's obviously very hard for some people to take an entire year, potentially very far away from their family, but to learn this. I know that there are some external fellowships, people coming for periods of time, and wanted just if you wanted to chat a little bit about that.
It's a fascinating question. I think in the neonatal hemodynamics community, we all know some of those people who have done that, and it's wow, what an incredibly disruptive to family life. Um, there are alternatives, but it requires, I think, some creativity. It requires, I think, dedicated time, and I think it can be done in an iterative approach. That iterative approach that I would prescribe is start with basic cardiac focus, move to advanced cardiac focus, and then harness local resources to either put together hemodynamics training or go for focused hemodynamics training at at highly specialized sites. Iowa is an example. So that's one way where you don't have to be away for a year, that's a non-starter for kind of people perhaps older in life or with established families. But that iterative approach can get you there. Um, as I said, the imaging feels like the biggest barrier, but in fact, it's not. So, the first step, number one, is you can be a neonatal intensivist without knowing how to image. So, if you're a neonatologist, step one is develop your neonatal intensivist skills, and that's far more than just echo. And then once you're an intensivist, and you already understand what the information from echo gives you, then simply learning to scan is just the cherry on top. And in fact, most of us, I think most some training programs do have sonographers. So from many times, at least here at Sunnybrook and in Toronto, I would say maybe I'm doing 20% of the scans myself. 80% of the time we have our sonographers do it, and we just, we burnish it, get a few extra pictures. But I don't have to get the images anymore. I have someone to help me with that. But the key is understanding what to do with that information.
Sounds great. Before we jump off to our closed session for the trainees, I will just like to thank everyone for joining today. Laura did put in